Hey everyone, it is Wednesday, and you know what that means? It is time for Humpday Happy Hour with Dennis in the Know. This is your backstage pass for current trends, politics, and education in the dental world. It is live. It's usually over a cocktail. Tonight, I don't know, I just wasn't feeling it. Had to just do a cup of coffee in a Dixie cup of all things. But anyway, it's great to be with you. Before we get into this any further, we're wishing all of our friends, particularly on the west coast of Florida, wishing you the best of luck with Milton. I know it's just coming in right now, and we are thinking of you throughout this whole thing. We hope everybody fares okay. But anyway, as I said, we're here to do a program, and I'm here to do it with two of my best friends in the industry, Dr. Chad Duplantis. Well, let me just say two of my best friends. How about period? Can I just leave it at that?
Yeah.
I don't need to say in the industry. That's stupid, right?
It's so narrow-minded.
It's like saying if I wasn't a dentist, I wouldn't be friends with you guys. But I am.
Is that true?
No, I think I'd like you guys anyway.
Of course.
We could hang. We could definitely hang.
But we would have never met.
We probably wouldn't have met, and that would have been certainly sad for me because I do mean it when I say I look forward to this every single week, and sometimes more than others, but this is one week I miss both of your faces. Chad, happy belated birthday. For those of you out there who didn't know, Chad turned half a century yesterday. So happy birthday. How did you spend it?
Thank you very much. Sorry, I got a couple barking dogs in the background, but
the dogs are still excited about the birthday party.
Yeah, we went to the Hill Country with some friends this weekend and did little Texas wine tours, and then we had Ellen and I went to dinner last night, and I tell you what, I'm just looking forward to the big game this weekend. I'm going to Texas OU and super stoked about that. So it'll be a fun weekend.
Very nice. Jennifer, how did you spend Chad's birthday?
That's really funny. Not celebrating Chad.
You didn't?
In my mind. In my mind.
Gonna Chad Duplantis in my mind.
I've been spending Chad's birthday trying to find the leak in our pool, in our new pool.
Oh, in the brand new pool. Are you kidding me?
Oh, no. Oh, no.
Yeah, that.
On another note, the yard is hydrated.
Chad has a couple of really cool things he wanted to talk about that happened to him for the first time in practice. But before we do that,
he got someone numb?
Yeah, he got someone numb. He prepped the right tooth.
Yeah.
Congratulations.
Congratulations.
Thank you.
Big day.
Oh, I thought you meant the 19, not 19. Oh, wait, there aren't 9 teeth in the quadrant. Hey, anyway, so I'm going to finish the intro first.
Okay.
As you all know, we are all business owners. We are all dentists. And we are all educators. And our job is to bring you in the know. So I finished that. Now, guess what? This happened to me last week coming home from Des Moines, Iowa. So you know who our guest is tonight, right?
Yeah.
Dr. Tom Viola, pharmacist and incredible pharmacist who has been lecturing, and he's just has so many accolades in our profession. He's been on scientific committees for the ADA. He's just done so much in the profession. One of the most sought after lecturers with regard to pharmacology in our profession. So Tom's been a great friend of the show, right? And so I'm just beat, still in my suit from the lecture in Des Moines. And I'm walking on the airplane, Des Moines, Iowa now. Okay. I'm not, this isn't Paris. This isn't LA. This is Miami. Des Moines, Iowa. Walk on the plane. and I see this striking fella, right? And he looks very official. He's got a tie on, like he's dressed the way people used to dress on airplanes. Like he's got the full tie on and everything, but like he's at it. And I mean, he's like, I think he's like firing people. I think he's buying low and selling high. Like he's on the phone and he is a man on a mission. And I look at him like, damn, that's Tom Viola. And I look up at him like I just want to go, hi, Tom. Hi. And he just kind of glances over in my direction and he's like, yeah, well, I said buy low and sell high. You know, he starts getting right back into his calm. I'm like, well, shit, maybe this guy just looks exactly like Tom Viola. So I'm like, I'm going to leave him alone. Obviously, it's like a Fortune 500 guy who I'm just bugging the shit out of by being
He's a businessman making business deals. Like just
this guy's making deals. This guy is at it. And so, of course, I got to crawl over him to get into my seat because I'm in the window seat and he's on the aisle. So I crawl over this important businessman and I'm sitting there. And then freaking finally, he realizes that I'm someone familiar, right? He's like, oh, I couldn't get away with dissing you. So this was it. This is what I see. And then finally, Tom Viola says, yeah, we could take a picture. It's okay. We can have a picture.
How much did he charge you for that?
It was $50.
Yeah, $50.
Yeah. And I offered to buy drinks, but we were in first class, so we got the drinks free anyway.
There you go.
There you go.
So basically, you're telling us that he was lecturing and he was selling stocks, so he was the only one on that plane making money.
Correct.
That day, right?
Pretty much. Yeah. So anyway, but it was so cool catching up with Tom, and we literally that flight lasted 30 seconds to me because we just chatted the whole way, and it was great conversation, and just love Tom. So everyone sit tight because Tom Viola is with us tonight. We're going to talk all things pharmacology in the dental world. And with that, we'll go to JB in a second. But I think Chad had some cool things that happened to him today.
Wanted to say some good stories.
Yeah. So patient knee replacement 2 years ago, right? When did the ADA and the American Academy of Orthopedics come out with the recommendation that antibiotic prophylaxis is no longer needed?
It's a while now.
Yeah.
Like 2012?
Yeah.
I think 19 was when they finally did away with it. They
Long
kept
enough that I could say
shrinking
it's a
the time.
So,
Maybe it was
patient comes in with letter from orthopedic surgeon that says antibiotics are necessary for dental procedures for you if the procedures are, and I wish I had it in front of me. I mean, the way it was written was so horribly worded. Okay. So the patient called, I told the patient, I was like, unless your orthopedic surgeon is adamant about it, then it's not necessary according to the American Academy of Orthopedics and the American Dental Association. So say the patient talks to the orthopedic surgeon, they send this letter over. And it says, in your case, antibiotics are necessary for a lifetime. Okay. Right. Whatever.
For a lifetime.
For a lifetime. So I read through the list. And like I said, it was just horribly, horribly written. Well, I kind of half-ass read through the list, right? And the patient has 14 OL and 15 DOL. All right. Basically occlusals with a little chip off of the distal marginal ridge on 15.
I think we're super gingival all the way, baby.
Yeah. So I was like, you know what? I know that they say that it's necessary, but it's not necessary. So the patient calls just up in arms that I'm numbing her and I'm not giving her antibiotics. And I said, well, what are you talking about? And it says any procedure involving injection of the gums. Okay. Any procedure involving injection of the gums. And so then I'm like, oh, I look like a dumbass because, well, I mean, I look like a dumbass because I am injecting the gums to anesthetize her teeth, right? So I end up and I call the patient and I'm like, all right, here's the deal. I said, I get what your orthopedic surgeon's telling me, and I get what, what they want. Oh, and at the bottom of the letter, it says, although we require you to take antibiotics, we will not prescribe them. You need to get them from your dentist.
That's what I.
Yes,
Which
I'm going to
just
tell you
sends
what
me
to do, but I will not take the responsibility of writing the prescription.
Sends me through the freaking roof. So I called the patient back and I said, look, I said, basically, whenever I get this from an orthopedic surgeon, it's never as descriptive as this. I said, and when I always default to the American Heart Association guidelines whenever this is the case. And it's basically anything that we do that can create a bacteremia or bacteria in your bloodstream. I was like, I'm not going to go against the orthopedic surgeon's request. However, I said, injecting the gums, I will anesthetize your tooth, but that is not a procedure that requires antibiotic prophylaxis. And I said, and what really irks me about this, and you can tell your orthopedic surgeon next time you see him, because I'll never talk to him, but you can tell your orthopedic surgeon that if they want the freaking antibiotics, then prescribe the freaking antibiotics. Don't say you're required to have antibiotics, but I won't write the prescription, because whose ass are they going to come down on if anything ever happens?
That's
right. It's not going to be them. It's going to be me. And it's, and I was like, I just got to use some common sense here and follow the next set of guidelines that I have. And I said, nothing that I'm going to be doing is going to be producing a bacteremia. And I said, so, I'm not prescribing you antibiotics. And I mean, in the end, she was appreciative of it, but she's like, it really pissed me off when I read through that whole letter and it said, it's required, but I won't prescribe it. She's like, that's not fair to you.
I'm going to tell you what to do, but I'm not going to take responsibility of actually writing the prescription.
Yeah. And it's like, come on, people. I mean, your political, I was going to say governing board. It's not their governing board, but their political board basically has come up with our political board, which is basically writes the rules for dentistry and orthopedic medicine, that, it's not necessary. And then I'm going to go against it, but I'm going to make the dentist prescribe it. So I was
on a whole tirade on the fact that half of them don't do pre-screens for dental. So they'll put these knees on infected patients.
Yes.
And then they come in and somehow me cleaning them, that is equivalent to flossing for the first time for most of them, is now going to suddenly throw a bacteremia that's going to shut down the entire system. Like it's just not logical. I just don't like rules that don't have any logic behind it at all. Yeah. It doesn't seem intelligent.
This is a true story. And I'll share it because it happened numerous years ago, but a number of years ago, I had a patient walk into my office with a cocktail in hand, which I didn't know was a cocktail until they were sitting at my desk in their styrofoam cup, shaking it. And the patient was beet red, kind of a angry Texan dude. And basically told me that he and his wife were in Mexico and she developed a brain abscess. Okay. And this is in June. And so they had to med flight her back from Mexico. She ended up having brain surgery. They didn't know the extent of the damage. And they went to the ER back home. And the first thing the doctors said was, when was her last dental visit? And
the same thing happened to me.
They said, he said, it was last month. Well, the last dental visit was in February. So 4 months prior. And immediately the doctor deduced that it was a result of the dental cleaning that she ended up with a brain abscess with no other contributing factors, but it was immediately a result of the dental cleaning. And this gentleman asked me if I would contact my malpractice insurance to help him offset his medical bills, because the ER doctor had told him that it was a result of the dental cleaning. So of course, I mean, I contacted my malpractice insurance and they're like, bullshit. I mean, I just contacted them like, hey, what do I do here? This is freaking crazy. And they were like, bullshit. This is ridiculous. You document that entire conversation and, let's come back to it. And, you're
going to have to culture that abscess and show me bacteria that are only found in the oral cavity.
Yeah. But even then, I don't think that would be a fair assessment.
And it's just
it would be like saying,
it's not, but I'm saying
your oral systemic connection doesn't magically stop it. You know what I mean? Like your oral systemic condition can always
easiest to blame. We're the easiest to blame.
Yeah.
I mean, there's no reason to pre-medicate this patient prior to, Yet, because I didn't, this patient developed a brain abscess 4 months later in Mexico after eating unwashed fruits and vegetables and drinking water down there. Yeah, had to have been the dentist in February.
Well, I want to ask our guest. This is great fodder for when Tom comes on. I mean, of the oral bacteria, which ones can actually cross the blood-brain barrier?
Yeah. Oh shit. Tom just reached behind him.
He's pulling out a desk reference right now.
He pulled out this book that says bacteria and barriers. Which do they cross? He's reading that son of a bitch. He's like flipping.
I gotta be honest, the cover of that book doesn't feel scientific.
Wait. You know what? It's not time for him yet, but he's got to come up. I want to see this book up close.
How's everybody doing tonight?
Good, Tom. How you doing?
You waited a long time to bring me in on this. This is one of my favorite topics, this antibiotic.
I know. I didn't realize this was the rabbit hole Chad was going down, though. He just wanted to talk.
Chad,
well, it just pisses me off. There's certain things in the world that piss me off. That's one of them.
More power to you. I always said the same thing, man. You want me to write the script? Are you kidding? You're the one that wants it. You're writing the script. I had to put the patient in the middle because there are patients and we don't want to fight the battle and lose the war. But quite frankly, that's just nonsense. And I agree with everything you said. Now, I will disagree with one thing that Jeff said because Jeff left out some important details that I need to clear up right away. First off, Jeff, you forgot that by the time I had turned around and saw it was you sitting next to me, remember, I had already helped the captain in the liftoff. And right. I had already helped everyone who had difficulty with their bag, putting it up in the overhead, while simultaneously working that deal on my phone, selling all that gold at the highest price gold has ever been in the last 5 years. You left out a few details, Jeff. I'm not going to lie. So I got
also managing a medical emergency, I think, in aisle 32 or
I was applying CPR to the guy in B right behind me in 5A. I was doing it all. So I mean, I was a little preoccupied.
And answering like lecture questions from your lecture that day.
Boy, Jeff, I'm so zoned in and doing whatever it was I was doing, thinking about what I'm thinking. How long did it take me? 15 minutes? And I figured out
it was a little bit. I was just sitting there and sipping on my drink and everything. And
Jeff, was he reading this book, The Stocks for Pharmacists? Yeah. Okay. I just was wondering if he was reading that book.
Yeah. Bestseller.
Little Rascals. I think it was
a while. Then you finally just kind of glanced over and were like, oh.
Well, I should have, and it was so funny
because started wearing off. I guess I don't.
Then again, I must say it was Des Moines. Come on, what are the
odds? Who are you going to run into?
Yeah. Well, I really did. I had, by the time I sat down, I was resigned to the fact that it absolutely was not you, because with that amount of contact, if it was, we would have been hugging and kissing and greeting and doing all that fun stuff. So,
and then anyway. Also, what I realized was on my backpack, on my $3,000 Toomey backpack that, I'm sure you're familiar with, it has my initials. So I'm like, at some point, Jeff would have looked down and said, oh, he
has the same initials.
That's the thing. But I was already looking down at your shoes to decide which foot I was going to kiss first.
Yeah. Too funny.
I was only going to go with the shinier shoe and
the ostrich leather, of course. Only guys making deals.
Rich Corinthian leather.
Yeah, I left my alligator boots at home, so I had to wear the ostriches on.
I know. It's a tough world when you're on the road all the time.
Yeah, you did. I will say this though. You look powerful, man. Own it. Own it. It was great. I was like, I'm not effing with this guy.
Well, so he looked like the guy who bought the first class ticket versus the guy who got the free
upgrade. Versus the guy who got the upgrade.
The upgrade.
And what you also should know, all of you, is that since I was born and raised in Brooklyn, everyone on that plane is an enemy until proven otherwise. Yeah. So I'm giving everybody the look like, all right, who's going to stand up and try to hijack the plane? I'm going to kill you.
Yeah.
That's so funny.
I apologize for that.
I love it.
Buddy, it is great to see you. We're going to let Jennifer do a little news segment, and then we're going to bring you right back on if that's okay.
Sounds good. Looking
All
forward
right.
to
Great
it.
to see you. Thanks for being with us, Tom.
Thank you, guys.
Okay.
We'll let JB do the news.
Go get.
All right, Tagger. So, a few news stories tonight. Nothing is super depressing. Again, we'll go ahead and send out our heartfelt wishes for a safe evening for those who are in the path of Milton, but also many who are still struggling from the aftermath of Helene. We have lots of colleagues. Obviously, I practice in North Carolina, so I have lots of friends that are out that way and lots of neighbors, et cetera, family members who live out that way as well. So providing support where we can. We'll continue to provide you updates where there's opportunities. I think right now the infrastructure has to get reestablished in order to even be able to go up and do a whole lot more from a dental perspective, but things are evolving on a daily basis. So we'll keep you posted. So there was a gentleman, I do a lot of jokes about the veneer techs. Maybe they're an easy target. I don't know. Maybe I'm just jealous that they get so many patients who want to pay them just a couple grand for some new nice teeth. And their cost of dental education was significantly less. Maybe it's all jealousy, but one did finally get arrested this week in Atlanta. And the darndest thing about this that I don't think I ever really put together was that his office looked like a dental office. It had dental equipment. He had all the advertising for veneer services, for cosmetic services. I checked out his Instagram. It doesn't say the word dentist, but everything about the page would make you think that he is a dentist. He offered education to teach you how to do your own veneers, and then he was doing veneers in his Atlanta-based office. He was arrested this week for practicing without a license. Maybe this is a warning shot to the other veneer techs, though I was reading another story where someone just got arrested for the second time in 6 months for going back and practicing dentistry illegally. So it seems to be an up and coming marketplace in the US economy. So probably more to come on that particular topic. There's been a lot of heated debate in our dental community. There was an article that was published last week about fluoride. It was from one of our own colleagues and it spurred a ton of debate. But there is a lot happening in the world of fluoride separate from that particular article, which I think we should take note of. We're coming off the heels of a lot of uptick in activity of municipalities relooking at their fluoridation programs to decide if they should continue with that program or not. And then we had the California federal judge say that he was unable to make a decision on whether or not it was ethical to provide fluoride in the municipal water supply. So he has deferred his decision back to the EPA, requesting that the EPA now take this up as an opportunity to relook at the fluoridation program to see if it's still in the best interest of the public health. And another article came out this week in a more scientific journal, looking at some of the different studies that have been done in more recent times relating to the benefits within a population and the fluoridation programs. This was published in the Cochrane database of systematic reviews. What they noted was that some of the original studies that came out about the municipal water programs pre 1975, where there was not so much fluoride present in our general population. So you weren't getting trickle down effect through all the different drinks and stuff that you purchase over the counter. The rinses that were available, almost all toothpaste now, unless you specifically seek it out, have fluoride in it. We're receiving fluoride in our dental offices, et cetera. So the uptick of fluoride ingestion and exposure has gone up pretty significantly. So the upticks that they saw in fluoridating the water supply pre-1975 and around that time period seemed more significant in the review of literature versus after 1975, where they saw sort of a leveling off benefit. So I think I don't have a strong opinion one way or the other yet, but I do think this is a very evolving area of our practice. And I wonder if fluoride will be the way of amalgam, where this will be the way we used to do things, but it's no longer part of the municipal programs anymore because the general population now is finding exposure in other ways. I don't know. I don't know where this will go. I think it'll take a decade or more for it to actually take hold if this is the way of the EPA to determine that we no longer need to pay for these programs. I can tell you this. When I went to dental school, I thought for sure as I was coming through dental school that I would see a decrease in dental decay in our population. And I'm not really seeing that at all. I definitely see teens coming through, probably more percentage that don't need treatment versus do. But the persistence of childhood caries, the persistence of adulthood caries, for those who are afflicted with the disease, doesn't seem to be moving the needle with or without fluoride. So I think it continues to at least warrant the discussion. Have we really identified and understand the etiology of this bacterial disease? And how can we help support our patients hopefully achieve a healthier life? And I don't have all the answers for that for sure. One last little story to share with you for this evening. We've got an IV shortage. So if you are an office that's performing a lot of sedations, implant surgeries, big surgeries, etc., I just wanted to make sure that you are aware that Hurricane Helene hit one of the largest IV suppliers here in the U.S. They're actually based in my home state, Marion, North Carolina. It's the Baxter International Factory. They make 60% of the IV solutions here for the U.S. Their facility has been shut down indefinitely due to infrastructure damage from Helene. No reopen date has been published. Now, they are reaching out to their international suppliers to see if they can redirect supplies back into the U.S. to help offset that. The current words of wisdom are that we should be judicious in our use and not be wasteful when we are using it for surgeries if we can control the flow. And maybe there are certain cases in which it might not be necessary. And do understand that you may have a delay in getting access, so it may impact how you schedule your surgeries in the next coming weeks. Be mindful and watch for those supplies. And I guess what I really should say is try not to hoard too much of it from your other colleagues. If we could all just have enough to get by, then hopefully we can get through this little bit of a bump. And with that, that's the news.
Well, what do you say we bring them on?
Let's do it. You want to introduce
the first
him,
time?
Jeff?
I liked it so much, I'd like to do it again.
Yeah. Chad, do you want to do an official intro for Tom?
Well, I would if I had it open. However, I don't. I was
You're really a
ready
professional, top notch.
But this is how I'm going to introduce Tom. And I'd be happy to do so if that's okay. Tom is a friend of the show. He is a longtime guest. He is the most world-renowned dental pharmacologist out there. He does lectures internationally, and he's highly sought after. And it is an honor and a privilege to have Tom on our show. And I guarantee you that I would not, y'all know me, I would not have stepped over Tom like he was chopped liver or anything. I would have yanked the phone out of his hand and given him a big kiss on the cheek and said, Tom, I love you, man.
You left one thing out of his intro, Chad. Our friend Tom Viola is engaged to be married.
This is true.
Holy cow.
Yes, absolutely.
That wasn't a secret you told me because you felt bad, was it?
That's like a Netflix special.
That is.
Nerds in Love.
Yes. It was 10 seconds ago, Jeff.
Hey, congrats, Tom. That's awesome. That's good stuff, dude.
Thank you very much.
Congrats.
Hey,
I'm a lucky man.
So happy for you.
I'm a lucky man.
Yeah. So where are we gonna get married? It was really, that's how good the conversation was, guys. Like literally, we decided to get married on that flight.
I will say this, it is going to be a secret that I will pass on after the fact. We want it really private. We want it really small, just her and I, and just like the closest friends we have. So I will share at the time. But it's it's a beautiful thing, and I just got super, super lucky. I don't know what happened exactly, but it changed my life forever. So I owe her just a completely different perspective on what life can be and what love can be. Because until then, even though I thought I was in the place that was right for me, you never know what a canceled Uber ride will do for your future. That's all.
Hey, Tom, what does she do what does she do for a living?
She's a hygienist.
No kidding. That's awesome.
Keeping it in the family.
Keeping it in the profession, baby. That's correct.
That's awesome, dude. That's awesome.
So
So I just think that's so great. Congrats, Tom.
Yeah.
Thank you so much.
And I hope
you deserve
wasn't
it,
a
buddy.
secret, but I was so happy for him. Like literally, like I was just, I could see the joy in his face, and I was like, I got to share that with these guys.
But
No,
honestly,
good
Tom
stuff.
shared with me later, it was really awkward when you got in his arms and were crying like uncontrollably in a baby position.
He
Like, I
pulled that
think
shit
that
on
was
you
too
too,
far.
Tom.
Oh, I will tell you, I don't know. The hug was pretty tight. I mean,
Yeah.
I was beginning to think that maybe I should take lessons, because if I don't hug that hard, then maybe people don't think I really mean it. Like it was a solid hug, So
Did you
Did his
slip him a
denture
tip
pop out
afterwards?
again?
Yeah.
all I could do at the end was say thank you for not stepping over me too many times to go to the bathroom. Because at my age, if I was sitting in that window seat, I would have been up every 5 minutes. Just saying.
Yeah.
Mazel
Yeah.
tov on your larger bladder. That's all I can tell you.
I think the hug is what provoked Tom to tell Jeff he was engaged.
Right. And
Absolutely.
Chad,
Jeff, I'm
if it
taking. I'm
makes you feel
sorry.
any better, Chad is younger than both of us, and he could have never had that window seat.
No.
No,
Mm-mm.
no.
Well, if
No.
you ask Carol's her name, my fiance, if you ask her, she'll say, yeah, don't give Tom the window seat. He always gets the aisle. It doesn't matter when he gets the aisle seat. Yeah, that's it. So
It's nerves, right, Tom? It's nerves.
it's nerves. That's it.
Yeah.
That and,
Well, think about all he had done prior to takeoff. I mean, that's a lot of nerves.
Hey, I did.
All right, Tom, do you have any comments about the fluoride discussion? I don't know if you have a strong opinion one way or the other. It's not kind of in the pharmaceutical world, but kind of.
I'm a big believer in fluoride. I always have been. I always will be. I don't think fluoridation in the water is as problematic as people like to make it sound. And I think it's something that we've done for years. And I think it has proven to be much more beneficial than not beneficial after all these years. Just from looking at people's teeth and how well they've done over the years, think about what teeth would look like today if we didn't fluoridate water.
For sure.
That's my opinion. I know the chemistry, I know the physiology, hydroxyapatite. I mean, I could spend an hour telling a layperson, all about how fluoride, strengthens enamel, but I'm not going to get through to that person if they're going to believe the latest and greatest news that crosses their screen that says, oh, there's another poison we need to worry about.
Yeah.
I just don't buy it. That's again, I am HO, right? That's just me. I'm not really speaking too much as a professional, as I am just someone who's been involved and around in dentistry all this time.
Do you see? I'm going to just do one follow-up, Chad.
Yeah, do that. I got something to say after that.
Do you see a place still for fluoride supplementation? Because I actually had that question today, and I hadn't actually thought about it in a while, because we have so many other delivery mechanisms now that I really haven't written a prescription for fluoride supplementation. Maybe I've written one in my professional career. So do you still see a place for that in the marketplace? And for providers who do get asked about that, what's the current conventional wisdom of when to decide, and is it still good practice?
I mean, I was a pharmacist in the days of polyviflor, and I'm sure you guys are familiar with fluoride tablets and all we did to dispense fluoride supplementation. I think the fluoridation of water was a good counterpart to supplementation. The problem you have, of course, is bottled water. Nobody wants to drink tap water anymore, understandably, because there's hormones in it. There's other chemicals in it that could be deadly. And so, I'm going to drink everything out of a bottle. Then it's really difficult. And forgive me if I'm wrong. I don't know everything about the subject. I don't know I think they make at least one brand of water in a bottle that's fluoridated. I don't really know much more about it than that. I think the majority of waters I've come in contact with just in my travels don't have fluoride. So I do think in that case, there may be a need for supplementation. But honestly, I just think, again, I'm wrong, but I think dentifrices with fluoride do the job.
Yeah.
I don't see
and varnish. You can do varnish, and other things. That's kind of been my MO, because what we don't know is the trickle down effect. And so you don't know when you're overdosing a kid, because there are some bottled water, if they're being fed in through a municipal water supply, you may get passed through, and juices, et cetera. If the water being added in is municipal water, it very well may have fluoride in it, even though it's smaller amounts by the time it gets through that process. So you start to lose track of like how much exposure is the child really having on a daily basis How do you adjust or quantify that to not over prescribe? And yes, there's like over prescribing where you see the neurological issues, but even just the staining of teeth and the discolorations and the things we saw with some over fluoridation, you certainly don't want to participate. It seems very counterintuitive to our profession. So
I agree. And I'm an old school guy, and I think, topical application beats systemic absorption anything. I could be 100% wrong, but that's just my opinion. Yeah.
Well, one of the arguments that everyone has had is, well, this is a neurotoxin. Well, so is zinc in too high of a level, right? Almost every element we have at too high of over oxygenating a patient can be problematic, right? Everything we have in too high of a dose is going to have some kind of a toxic effect. And so, to say that, it's like, I think there just needs to be an understanding of what are those levels and developing a strategy for where you are. I mean, if you have a child with developing teeth, of course you want to make sure that they're receiving a proper amount of fluoride, which has been proven to be safe at 1 part per million, right? We've proven that. We've proven that over and over again that it's safe by generations of disease eradication without kids having neurological problems. So, I think the data's out there, but, there's always people who just kind of grasp at that. Well, I heard fluoride is neurotoxic. Well, so are a lot of things in too high of a dose. And I don't know.
Well, we've got, the benefit of stabilized stannous fluoride now, which we didn't have, 30 or 40 years ago. And that makes a difference. It's available over the counter. It's something that anybody could pick up and start using. Heck, I don't know much about it, but I know silver diamine fluoride is fluoride. I can tell you that much. Yeah. My limited knowledge. So we're happy to put that on people's posterior teeth when necessary to stem decay. So what are the long-term ramifications of that? I don't know. I don't know enough about the product, but I just think that fluoride has probably done more good in this world than bad. That's just my opinion.
I would agree.
Chad, were you going to say something? Is this probably not very important now?
Oh, hi. How are y'all doing? Actually, I was going to say, I believe the brand of water with fluoride in it is Nursery Water. The brand that used to be. But you kind of hit the nail right on the head, Tom. I was going to just kind of allude to the fact that, topically versus systemically, there's a huge difference. However, right now I am drinking Flow Clo Chico. It's a little bit of fluoride, a little bit of chloride, a little bit of Topo Chico, and a splash of lime, and it is freaking fantastic. I'll tell you, it is good. Not a neurotoxin at all, but I'm telling you, it's fantastic.
That just makes me want to move to Tejas, buddy. I mean, really.
It does. Sign me up.
Yeah.
Come on down. So, hey, let's get on that. Let's get on that topic of prophylaxis. It seems like it's always something we bring up with Tom, but man, I don't think you can talk about it enough because it's such a problem.
My opinion of prophylaxis has changed a lot over the years, but it was really, a couple of groundbreaking studies that were published. Martin Thornhill, who out of North Carolina and London, he's pretty much, the most prolific writer on this, really put forward data in 2022 that said, it was that landmark study, 1.6 million patients, who had just the right criteria for the study, and proved without any doubt that invasive dental procedures can cause infective endocarditis in patients who are susceptible to such. And then antibiotic prophylaxis negated almost all of that effect. So there was demonstrative evidence that suggested and proved that 1, it did work, and 2, it did work. So where was the disconnect after that? Joint replacement infection, though, by contrast, is even more of a slam dunk. Because in 2015, the ADA said to all of us in dentistry, stop doing it. It doesn't work. Stop doing it. And by the way, if that didn't get through the first 2 times, stop doing it. But we still have orthopedic doctors who swear, give my patient amoxicillin for the rest of their lives and their kids' life too. Like, when does it end? And the point of all that is, I've had a lot of heat for this, folks. I'm going to tell you now. I bet you'll get some of the comments after this show is over. My opinion was, you can follow your heart and say, I am not going to prescribe. There's no evidence to suggest it works. Moreover, there's evidence to suggest that it doesn't work, again, by Martin Thornhill et al. So why would I want to prescribe? And heck, it's not even my decision. It's your decision. So you write the script. I get all that. And here's the downside. It's the patient in the middle. And if the patient for even 1 second believes that because you didn't give them amoxicillin, they have to get that joint replaced a second time, not only will they blame you for it, even though you had nothing to do with it, they will tell everyone they know. And not only that, you will lose that patient. So you won the war, and no, you won the battle and you lost the war. You've now alienated that patient forever. I'm not saying to the point where it involved malpractice. Gosh, I hope not, Chad. That'd be ridiculous. But I see your point in how you handled it, because heck, I would have done the same too. The bottom line is this: maybe we don't want to die on that hill. I've said that. People get annoyed with me. Hey, what about you're a pharmacist. You should be all about, stewardship and not exposing us to antibiotic resistance. I get it. But every doctor I know in New Jersey, every pediatrician I know in New Jersey overprescribes amoxicillin. Maybe I don't paint with that broader brush. A lot of them do. So who are we really fooling? If amoxicillin is as wide prescribed as it is, does it matter if it's our 4 capsules or the 30 capsules a medical doctor gave to a patient who may or might not need it, but they have a sore throat?
So, you bring up two points that I want to hit on. And the first really relates to what you're talking about, is that a lot of this, it's he said, she said, they said, we said. It doesn't matter. It becomes a pissing contest at the end. And so where I'm headed with this is, do you do any like expert witness stuff? And does this ever come up in any of the cases that you do where, okay. It's just nice to know that there's advocates out there for us, because that's what scares me the most. There is just the pissing contest of the whole thing, is that, and it's the fight that we have to go through to at least quote unquote win, Yeah. I mean, it's frustrating.
I've had detractors who've come up to me, other speakers, other clinicians who've come up to me and said, it's obvious you've never treated a patient in your life. And my retort is, it's obvious you've never been in court yet.
Mm-hmm.
Because I've been there and I've seen it, and I've seen the outcome. And again, I don't want anyone, and I love you guys, so let me put it this way: I never want to see you again. You know what I mean?
Yeah.
Not there, okay. Here's fine, but not there. You don't want to be there, because everyone's going to armchair quarterback everything you did. And at the end of the day, what did you accomplish? To me, it's not worth it.
It's funny. It brings up another point. There was something that happened at the office today, and it wasn't in regards to anything that I had done, but it was in regards to what a previous dentist had done and the way that the previous dentist office was handling things. And I sat there and I was like, this is a case that's probably going to go to the state board. And my assistant comes in and she goes, I think you should write these notes. And it was like 2 pages of basically everything that happened in that room. Not because I did anything wrong. I mean, it was my first and maybe last time that I'll ever see this patient. But I just knew that this patient was about to take somebody to the state board, and they're going to subpoena my records. And I'm like, you know what? I'm going to make sure that all of my T's are crossed and my I's are dotted because of this, And, I do have that article, or I can't even think of the word right now. Basically the declaration that, the AAO and the ADA came up with when antibiotics was not, required anymore. But in our standard, in our profession, I never really want to go against an MD either. You know, if an MD tells a patient that, it does put the patient in the middle. And if it's reasonable, I'll do it, you know, but for injection into the gums, or as some of my patients say, gooms, it's just not something that I want to do. So I'm passionate about it. So
yeah. Couldn't have said it better, Jeff. And let me say, just real quick, you know, the three most important words I tell everybody in my lectures, and I'll tell you guys as well, and all the listeners, three most important words: and document, 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 document everything, because you don't want those people are not a jury of your peers. They are not your peers. They're hand selected to not be your peers. The only person in this world you have to impress with your knowledge and with your the notes that you take, State Board of Dentistry, in my opinion. You can always pay a fine. You can always settle a suit. Can't always keep your license. So you bring your case before the State Board of Dentistry. You show them what a prudent dental professional would have done in that situation with your lengthy notes, and let the civil stuff be damned. It doesn't matter, because anyone looking at your notes later could say, wow, this doc really did care about this patient. When you don't document because you think, they're just going to use it against me, that's when people armchair quarterback you and say, I would have done this. And how do you protect yourself then?
Yeah.
So I have another question.
Or I'll have another.
Yeah.
Say again, I'm sorry.
I thought the three most important words were I'll have another.
Those depends on where you are, Jeff.
Not at work.
Can I ask
for a myriad of reasons?
Oh, there's always a caveat.
Yeah.
Yeah.
Tom, this is not to put you on the spot, but you know, since we're on the topic of antibiotics, and I know it's always a popular topic, I want to ask, do you have is there literature out there that suggests that antibiotic allergies are past, like, or are familial? So like if my wife and I are both allergic to an antibiotic, would our children possibly be allergic to that antibiotic? Or is
I mean, I could be dead wrong, but I've never seen anything that said it's familial, genetic, or hereditary. I've never heard.
Okay, so the reason that I ask, I'll share the story. I think Jeff and Jennifer know this story, but my daughter was in the hospital in April, and the doctor said that they were going to give my daughter a huge bolus of amoxicillin. And I was like, you know, my wife, myself, my son, my father, my wife's mother, you know, we're all allergic to penicillin. And the doctor was adamant there is absolutely no literature that suggests that she would be allergic to if she's never had a reaction. We're like, well, she's never had a reaction, but she's never had it either. And about 30 seconds into the treatment, it seemed like it went haywire on her, and I've never seen that reaction take that severity on that quickly. And so I just out of curiosity, because that's another thing that I always worry about when I'm prescribing these antibiotics is allergies, you know.
Yeah, and I will tell you that I've seen people truly allergic, and I've seen people just believe they're allergic.
Mm-hmm.
And
I've always wondered what's what, you know.
And you really can't tell. I mean, honestly, I always take people at their word for it, only because I don't want to find out I'm wrong. So
well, and it's hard to know too, is it the actual medication itself or filler, dye, coating, who knows, honestly. So then, you know, you could have had a reaction to the amoxicillin that was generic that you were given at 4, but if you took it today, which is not probably made by the same company, probably totally different fillers and all the other stuff, would you have the same reaction or not? Who knows?
Until watching that happen, I would have, I literally had said the next time I'm prescribed antibiotics, I'm just going to take amoxicillin and see what happens, because my reaction was at 4.
And now you're like, nah, I'm good.
Now I'm like, no, we're not going to do that. We're not going there. Nope. After watching that was not fun. The EpiPen.
Maybe use Ava as a pin cushion.
Yeah.
So while we're on the topic of antibiotic use, and we had talked about stewardship and the overprescribing for a long time for, you know, every little sore throat and things like that. Interestingly, my mother recently was put on long-term antibiotics for management of a recurring urinary tract infection. Now, I'm not blaming anybody. I'm just telling you the sequela of what happened. And I'm sure, I mean, you have to treat the urinary tract infection, or, to some degree prevent them, because those can be, I mean, they can really take down the elderly. I've seen it. I've seen what a UTI can do. But she was on it for quite a while. And then at home, she just noticed that she was, all of a sudden she could not have a solid bowel movement. And she just put it up to indigestion, or, just not feeling well and things like that. And as it turned out, she had C. diff, and ended up in the hospital. And what was interesting to me in talking with some of the physicians and nurses is the increase in incidence of C. diff now. And a lot of them attribute it to the overuse of antibiotics. So I'm just curious what your thoughts are on all of that, because there is this place that we do have to be conscious about being good stewards of scientific and sound use of antibiotics. But like you said, you also don't want to be the guy who didn't give it when the patient thought they needed it, and then God forbid something happens to them and you're on the hook. So what's your opinion on all that, Tom?
I would agree that the utilization of antibiotics and antibacterial agents increases the risk of C. diff, but I also would have to point the finger at the use of drugs like omeprazole and esomeprazole, Nexium and Prilosec and Pepcid and Zantac, and drugs that reduce the stomach production in your stomach acid production, because stomach acid really is one of your first lines of defense against C. diff. So if you're wiping out your stomach acid, there's really no defense for C. diff. And realize that the current antibiotics that we have really aren't effective against C. diff. So once C. diff enters your bowel, it pretty much takes over, because normally the good bacteria in your gut keep it in check. But if you're taking an antibiotic that has efficacy against them, even if that antibiotic is bacteriostatic, eventually the good bacteria are overwhelmed by C. diff, and C. diff takes over. And that can happen quickly. I've seen people develop C. diff-like symptoms and be in grave danger in 6 to 7 days.
Yeah, my mom got really sick. She was in the hospital nearly a week. And it took a $1,500 medication to finally get it under control after a few days. But what if people can't afford that $1,500 medication because they tried her on every other thing, and it wasn't until she got the Difficid that she made any progress, and she did have to pay out of pocket for that.
Hey,
so
Jeff,
yeah.
I apologize if you said this, but I didn't hear you say it. What antibiotic was she prescribed long term?
I believe it was doxycycline.
That's kind of that's what I was thinking, but and it just goes to show that Clinda's not the only one.
No, it's not. And I thought,
It's true.
what if, was it a long-term fluoroquinolone? I sure hope not, but no, by most accounts, someone with recurrent UTIs, that's not an outrageous protocol for a physician to take. But so what do you do? I mean, the urologist has to help her with the UTIs. He can't not prescribe it or risk having her develop another, threatening UTI. But as it turned out, when she went in the hospital, she still had the UTI and the C. diff at the same time. So imagine that balancing act for the hospitalist, right?
So many people are on doxycycline long term.
Yeah.
Oh, yeah. Especially for acne and rosacea.
Mm-hmm.
Yep, absolutely.
Exactly. And even for periodontal disease.
Question.
So, but you made a really great point, and I hope everybody heard that, because I didn't really think about this so much, because my mother also has been on long-term omeprazole.
Ding, 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 ding.
Yeah. And I've often said from the sleep apnea perspective, why are we not trying to get to the root of why the reflux is there versus shutting off all stomach acid, which, it's that acid that protects us and helps us break down foods and vitamins and all the things that we need. But I didn't really think of it in those terms. So maybe we should take extra precaution on those patients that also happen to have, omeprazole or esmeprazole or, any of the proton pump inhibitors. Maybe we need to be really thinking about those patients when we're talking about antibiotic therapy for whatever reason.
Yeah, I think so 2 points, folks. Number one, so glad your mom's okay.
Thank you.
Fidaxomicin, great drug, deficit. We don't have many. We have fidaxomicin, a deficit. We have metronidazole that has some efficacy against C. diff, and we have vancomycin. But we don't want to mess around with vancomycin because it's really like our doomsday drug. It's the last of the last that we can use in some really almost impossible infections.
She got Vanco and it didn't work. It wasn't until she got on the deficit.
Yeah, I was going to say, I'll bet you it didn't work because, again, we've used it in such stubborn cases that now there's resistance growing as well. Mm-hmm. The other point I wanted to make was to Chad's point, which is a good one, which is any antibiotic can cause C. diff. It's not just clindamycin. Now, correct me if I'm wrong, guys. I haven't seen it yet, but you are very knowledgeable, and I respect you immensely. Collectively, your knowledge is second to none. Has the ADA put out a statement that says dentists should not be prescribing clindamycin for dental infections? I know about the infective myocarditis prophylaxis, but I'm talking about dental infections as far as you know. Have you seen
Not that I'm aware.
I have not seen anything.
Mm-mm.
It's a great question. Should ask Bob D.
We all know that for as far as antibiotic prophylaxis and everything that we have moved away from clindamycin, but I don't think neither the ADA or the AGB
they actually did. Hang on.
Oh, they did. Mm-hmm. Look at you.
I thought I had read something, but I just wanted to make sure. They're putting it under their good steward use of antibiotics and that they no longer recommend it for prophylaxis or therapeutic use, which, and that came along with the AHA. So looks like in April of 23.
So they told us to stop using clindamycin for dental infections?
They recommended it. That's correct.
Okay. See, I've always been struggling with this because I've yet to see. Normally, the ADA puts out like this thing that says, here's a new clinical practice guideline, and I haven't seen it, so I was unaware. But thanks, and thanks for telling me.
Yeah, of course.
And
we'll publish that as well because I think that's important. But
I think so too.
Yeah,
I would love to see kind of a updated flow chart since Clinda's
correct
out, an updated flow chart of A to B to C to D, because honestly, it's been my experience, we don't have a lot to work with.
Sure don't. We have a great arsenal, but it's
we
small.
really don't. I mean, my go-to right now, if I've got a patient that's not allergic and they've got a rager, I'm going Augmentin. I mean, it seems to work probably the best, and after that, I don't want to prescribe Clinda, but honestly, I haven't been prescribing a lot of antibiotics lately.
But I think they're wanting azithromycin rather than the clindamycin now.
I've just had such bad luck with that. I just go to Keflex.
Yeah.
Yeah. So,
and so I'd love to see kind of an updated, and I'd love to see some new players in the marketplace.
Yeah.
So a couple
I do know for a fact that there is a fantastic non-opioid analgesic that's coming out, and they're really hitting orthopedic surgeons. And my cousin is a regional manager for this company that's just hitting the market, and he's trying to integrate the oral surgery market on this analgesic. Tom, I'll have to introduce you because everything that he's told me is fantastic about this. I don't want to let too much out on live TV here, but it's I think it's going to be a game changer, and I hate that word, but I think it's going to be a game changer.
It's called tequila.
Yeah.
Really
Really quick though, Tom brought up all the pivotal scientific reviews that were done early in this journey that documented and proved that antibiotic prophylaxis did have beneficial effect. Just out of curiosity, though, the antibiotics that were used during that time period, how far away are we from those original recommendations? So if the original studies were based on, let's just say, penicillin and clindamycin or some, like, when are we due or are we overdue now? Because the target has moved quite a bit from that to do another scientific review to say that these new players in the marketplace are equally as effective at bacterial and endocarditis prevention as the original protocol was.
Great question, because that was like the PVK erythromycin days, I think, when those came out. Great point.
So, one of the things that deterred me a little bit from even making the comment or even asking you the question, Jen, was because I felt like when this happened a couple of years ago that the American Heart Association started to lead the way for the American Dental Association and all of us. Like, okay, so if you look at the prophylaxis guidelines, they say now what? Don't use clindamycin. Okay, that's out. What's your option? Cephalexin. Okay, but if you're allergic to penicillin, there's still cross-sensitivity.
Yeah, absolutely.
Now, I'm not pointing fingers, but I've been to some lectures where some people have said and recommended use of cefaclor or another second-generation cephalosporin, because second-generation cephalosporins don't have the same cross-sensitivity that first and third-generation cephalosporins do. However, the guidelines are very specific, including just first and third-generation cephalosporins. So to that I say, if you don't want to follow the guideline, then don't follow the guideline. Then do whatever you want. But the guideline's there for a reason. It's not there to mix and match. Okay, now put aside cephalexin, azithromycin, as Jeff said, is our next option, right? Or clarithromycin. But even though people will flame me online for saying this, okay, there is some evidence to suggest that azithromycin can cause QT prolongation and cause risk of arrhythmia. Okay. And drug interactions. Okay, put that aside. What's left? Now we go back to Chad's point, which is, okay, I guess we're going to go with doxycycline. But doxycycline is bacteriostatic and really, in my opinion, doesn't do the job. And now if we step out of that to answer Jen's question, no, we need a whole update now, because I want to be out here. If I'm a dentist prescribing for dental or odontogenic infection, I don't know what to prescribe anymore because I'm getting all this conflicting information. But I know if the patient's got deep-seated, like a bone infection, heck, I always use clindamycin for that. Why would I stop now? So I put that back in your court, folks, because you're the experts and there's not me. I just wanted to throw that out there for your consumption.
Well, it's interesting. Sorry, Chad, really quick. It's interesting they pulled back on C. diff with no reference to what you said about what's its combination with Nexium and, all these other things. Like, it's just, Clinda is a terrible drug and no one should be giving it to anybody anymore. And, it's unfortunate in a scientific organization that we don't say worsened in combination with, used with caution, without, like,
Honestly, that was my biggest takeaway from tonight. Like,
for sure. It leaves our doctors in alert to just throwing darts at a dartboard at this point, because, if they can use amoxicillin or those first lines because there's no allergy, they feel really confident in that arena. And the further they start to step away from that line, the less efficacy they expect to see and the more cross adverse reactions and concerns. It's like, well, I'll give you this, but it comes with a caveat. I'll give you this, but it comes with a caveat. Like, there's always these extra things that then have to be said. Yeah. So,
Chad,
thanks for indulging us tonight on that.
No, it's okay. Chad, what were you going to say? I'm sorry. I didn't mean to.
No, I was going to say that Jeff was yelling at me. He was telling me that I got to close this out because we're like way over. But
that was as fast as our flight, Tom.
But here's the deal. I could talk to Tom for hours, and it's really funny because for those of you that don't know how this show works, a lot of these people that are on here are our friends. And Tom, you're considered in that friend category. Don't worry, I'll be at the wedding. Just give me a ring. We're good. But no, seriously. Tom is such a friend, but we always text, hey, what are we going to talk about tonight? If you look back on every show we've done with Tom, somehow prophylaxis comes up in that conversation because it's such a divisive subject in dentistry, if you will. So as Jeff has forced me to close tonight, because I could have gone on for hours, I will say this. There is a lot of money to be had if anybody wants to put money into pharmacological research for dental infections, because I think we kind of get the short end of the stick when it comes to the research. And for those of you that have ever had a toothache, personally, thank God I haven't, but I have heard from people that it is some of the worst pain that you can ever have in your life. And we need to have ways to manage these people. If Clinda's out the window, I mean, that was my go-to.
And opioids are out the window. What do we have left?
Yeah. Yeah. So you know what?
Again, tequila.
We got Rets, vitamin C, and cocaine. That's all we got.
Yeah.
That's all we got, But hey, with that being said, I want to close out the show, and I want to close with this. Is that sometimes in dentistry, we talked about fluoride, we talked about prophylaxis, we talked about orthopedic surgeons, we talked about passing the blame on to the dentist by a number of medical professionals. But I'm just going to say that sometimes in dentistry, we just have to sift through this and decide what is and what isn't. And let's close with this. Oh, this little bastard better start talking for me. Come on. Have you heard this little kid?
Come on, little cutie. You can do it.
Yeah.
I don't know. I can't get it. I can't figure out how to get the video to play. But have y'all heard this kid?
No.
This kid, it's like he sits there and his mom's like, "What did you say?" He goes, "Bullshit, bullshit, bullshit." And it's like it's the best thing ever. And so it's like it to me, just hearing that little kid say bullshit, it just tells us what we have to decipher in any medical profession is what's bullshit and what's not, because unfortunately we're fed a lot of it. So put your money into dental pharmacological research. And with that, that's our show. Tom, thank you so much for being here. And always an honor to have you, my friend.
Thank you all for what you do to the professions of dentistry, folks. What you do is second to none. Thank you so much for everything you do.
I appreciate that. For the other, I can't speak for the other two, but Tom, I knew who you were talking to when you were saying we're smart. I knew it. Thanks, buddy.
And it's only because we have a hotline to Tom.
Appreciate you, Tom. Again. Thanks, everybody. Good night.
We got more to talk about. Have me back again.
Take care, everyone. Good night.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.